Awesome. Welcome back, everyone, to session two, roles in research, stories of what these look like and offer. I'd encourage you, just like in the last session, to put your questions in the Q&A. And if you have resources and things to share, please put that in the chat. But for right now, I'd like to hand over to the facilitator for this session, Marie Ennis-O'Connor. Marie, floor is yours. Marie, you're on mute.
Rookie mistake.
There you
Thank
go.
you,
Welcome.
Joe. Thank you, Joe. And hello to everyone who's joining us today. I'm really thrilled to be here with you for this session on roles in research. And I'm joined today by two expert patient partners. I have Cheslie Johnson and Josef De Guzman. And Joseph is currently away at a conference, so he's going to be joining us via recording. You're going to find a link to the bios of all speakers in the chat function, and each of us will briefly introduce ourselves during our presentations as well. So here's how our session will flow. Each speaker will share a short presentation, and after the presentations, we're going to move into discussion and audience Q&A. So as Joe have said, please feel free to add your questions to the Q&A tab at any point, and we'll gather them up for the discussion after we've all spoken. So I am the first person to speak, and I'm going to introduce myself to you now. So, as Joe mentioned, my name is Marie Ennis-O'Connor, and I'm joining you from Ireland today. And I've worked in patient advocacy for the last 2 decades. I know I don't look like it, but I've worked since a diagnosis of breast cancer in 2004. And my background is in science communication, but I didn't choose to do the work that I'm doing now as a conscious career choice. Rather, it was driven by my deep desire to close the gap between evidence and daily realities and to align research outcomes and research measures more closely with patient priorities. And for me, it might be a little bit surprising to say, because I often get asked the question, how did you get started or how did you end up doing the work that you're doing now? And actually, my entry point was really simple. I was invited to tell my story at an event, and then I was invited to some more events, both online and in person. Now, you might be thinking, well, speaking isn't really a research role. And of course, you're right. Strictly speaking, it's not. But actually, I really believe that how we tell our stories can reveal with great clarity where perhaps a care pathway has broken down, or why what sounds like a great research outcome or measure really is missing the mark for patients' daily realities. And so storytelling is often the bridge into roles where patient voices can directly shape research. And that was certainly the case for me. And over time, what changed was I learned to pair my story with a solution. So I didn't just tell my story and say, oh gosh, this was really hard for me. But I said, actually, here's the question I really needed answered, and no one answered it. So I had to set off and find that answer myself. Or here's what really would have helped me to get that question answered. And I think it's that combination of lived experience plus practical solutions that really opens the door to more sustained involvement. And so from there, I was invited to join clinical trial steering groups, research ethics committees, and patient advisory boards and groups. And from there, I ended up helping to refine research questions to better reflect patient priorities, to improve patient materials, patient websites, and to plan for dissemination so that results don't stall at publication. So let me share with you one really quick example. A few years ago, I was involved in reviewing a consent pack for a clinical trial. And on paper, this met every regulatory standard, but gosh, the language, it was so dense, it was so off-putting. And I thought, if I'm struggling with this and I have some familiarity with scientific language and medical terminology, how on earth is someone who's perhaps newly diagnosed, who's scared, who's time pressed, how are they ever going to take this in? And so we proposed three practical changes. Firstly, a one pager. What does this mean for you? A summary in, I was going to say plain English, but in lay person's terms. Short sections framed by clear questions. Why this study? What will happen? What are the risks? What have I changed my mind? And then a pilot with a small group of patients incorporating their feedback before a final approval. So, what I like to say is that clinical trial protocol didn't change, but the experience changed. And that's the value that a patient partner brings. Asking, would this make sense on my worst day? And then staying with the process until the answer is yes. So, for myself, alongside committees and protocols, I've taken on roles that focus on translation and reach, research dissemination, because research isn't finished until it's understood and it's used. A paper that sits unread in a journal, and it still happens, is like, I always say, it's like a locked medicine cabinet. The treatment is there, it exists, but it doesn't actually reach the people who need it. Now, it really frustrates me because communication roles in research dissemination is sometimes undervalued. It's seen as perhaps an afterthought or an add-on, the softer side of research. But it's really important because this dissemination piece, and this is where patient partners have a huge part to play. This is where evidence meets everyday life. So whether it's a lay summary or it's an Instagram reel or it's an infographic, the goal should be to make evidence readable, relatable, and usable. Now, my role as a patient partner has evolved a lot over the last 2 decades. And as it did, I came to realize so strongly that the real test of patient partnership isn't being parachuted in to tell the patient's story or to fill numbers. It's being involved early enough to influence decisions. So the work that I do now, and I love the work that I do now, it's to focus on mentoring patient partners and research teams to create measurable value adding frameworks. And this involves clear role descriptions that pinpoint precisely where patient input is most useful. It involves closing the loop and feedback. It involves plain language, plain lay language pre-reads to make sure that patient partners can fully contribute right from the get-go. So when I mentor patient partners now, I tell them your role is not to tell your story. Your role is to tell the story that research needs to tell so that that shift from storyteller to story shaper has been the arc of my journey. So I want to leave you with a couple of things. So I want to say to patient partners, your story, don't ever think your story is just a story. It has immense value. Use it to show which outcomes truly matter to you and to your community, and practice telling your story in ways that point to solutions. And for researchers that are listening, involve patients early, define roles clearly, be really clear about what a patient partner can bring to the table and make that happen. Write for understanding and then test in real world settings with patients and families. Evidence only gains power when it's translated, when it's co designed and acted on. And the best partners, in fact, the only partners for this work, are people who live the reality every day. So thank you. And I'm now going to ask Hetty if you could cue up Joseph's video. Um, and we will hear from Joseph now before we move on to Chesley. Thank you.
Good morning, good afternoon, and good evening, wherever you are in the world. My name is Josef De Guzman, and I am a patient advocate from the Philippines. Many years ago, my life was defined by a fast rising career in sales and marketing. By my late 20s, I had already become the director of sales and marketing for a multinational company. I thought I had it all figured out. I was living fast, always moving from one win to the next. My identity was built on achievement and recognition. Then psoriatic disease entered my life. That was more than 20 years ago. The diagnosis didn't just interrupt my career. It shattered the story I thought I was writing for myself. At first, I felt like I had lost control over my own life. I was no longer the author of my story. I was a character being written by something else, by my condition. And I know many of you are patients or advocates may understand that feeling. But here is what I discovered. We may not choose the illness, but we can choose to rewrite the narrative. That shift in mindset became my turning point. From being in the spotlight, I suddenly found myself hiding. From leading conversations, I became silent, hoping people would not notice me nor my skin. There were days when I wanted to disappear. There were moments when I felt invisible, except for the disease written all over me. In search of a new path, I went back to school to study filmmaking. I thought if I could not be in front of people anymore, maybe I could make an impact from behind the camera. Maybe people would not see me, but they would still feel my presence in the stories I helped create. That search for purpose slowly brought me into advocacy. I began volunteering with health groups like cervical cancer, epilepsy, hemophilia, schizophrenia, and many more. I wanted to give people like me a way to tell their stories with dignity, in a way that people would listen and care. And then, 20 years ago, Psoriasis Philippines was born, not just as a support group, but as a movement. We wanted a collective voice that could push for change. That decision changed everything. From that point on, doors began to open. I was elected to the board of the International Federation of Psoriasis Associations, or IFPA. I started speaking at medical conferences, not as a subject of research, but as a voice representing patients. I collaborated internationally with other health communities, and I took on the role of mentoring advocates who were just starting their journey. Then came another turning point. I was invited to join an institutional review board. For the first time, I was no longer just a patient sitting in a clinic. I was reviewing research protocols side by side with investigators and doctors. My role was simple but profound: to be the patient's voice in a room where decisions are made, to ask the questions others might overlook. Will this procedure be too painful? Are there too many clinics visits for someone who still needs to go to work? Can an ordinary patient even understand this consent form? Or is it just a legal language? In this role, I realized something. Patients can be more than participants. We can be guardians of safety, dignity, and humanity within research itself. That experience became my training ground. It prepared me for the work that I do today at the Philippine Health Research Ethics Board. I now serve on the Committee on the Patient, family, and community engagement. Here, we don't just review a single study. We set the standards for all health research in the Philippines. But we don't stop there. We actively train and empower other patients to take on these roles. We build capacity, we build confidence, and we create a pipeline of future leaders. Because one voice is not enough. We need many patient voices, loud, clear, and informed at every decision-making table. This national work opened my eyes to a larger calling, a regional perspective. Today, I mentor patient leaders across Asia Pacific and beyond. I share our lessons in the Philippines, our successes, but also our mistakes, so that others can adapt and build on them. This is about creating a stronger, unified voice in the region. And here is where I want to pause, because for this work to be sustainable, we must move away from treating patient engagement as volunteerism. This is not a hobby. This is expertise. Patient advocates bring insights that no textbook or clinical trial can provide. That expertise deserves recognition and compensation. Fair pay is not just about money. It is about respect, equity, and sustainability. And beyond compensation, institutions must be ready to share power. Look again at the arc of this journey, from being a patient to creating a community, to becoming a guardian of research, to shaping national policy, and now to building a regional movement. Patients are no longer subjects. We are not just advisors. We are becoming architects of the ecosystem itself. And that is the message I want to leave with you. Your role can grow. Your voice can scale. Whether you are reviewing one consent form, mentoring another patient leader, or helping shape policy, we are part of a global shift that is changing the face of research. To my fellow patients, do not underestimate the power of your lived experience. And to my colleagues in research, invite us, compensate us, and trust us. Together we can build research that is not only for patients, but built with patience. Thank you.
Thank you so much, Joseph. I furiously writing behind the scenes. So words like trust, guardians, expertise. I'm really excited to hear what Cheslie is going to bring now to the discussion. So, Cheslie, I'm going to hand over to you and looking forward to hearing from you.
Hi, everyone. I'm Cheslie Johnson, joining you from Raleigh, North Carolina, and I've worked in patient research for about 14 years now. So my journey began in a hospital room and hearing a knock at the door and someone asking permission to enter. In front of me, three women who explained they were with the Patient and Family Advisory Council and would like to ask me a few questions about my hospital stay. I said, sure. First question, is your hospital stay satisfactory so far? No one had ever asked me that face-to-face before. I would just get some type of survey after my hospital visit. I answered truthfully, and more questions were asked. After about 30 minutes, the nice ladies wanted to know, left, and I felt like, wow, they just wanted to know what my experience was. Patient and Family Advisory Council. I'm thinking, what's that? What do they do? A couple weeks went by and I received a call asking if I wanted to be on their Family Patient and Family Advisory Council, or PFAC for short. After talking with the chair of the council and doing my own research, I was shocked that such a thing even existed. I said yes. not realizing how that yes would change my path on a professional and personal level. Wow, my perspective mattered. That was 14 some years ago. The notion what I thought mattered is what drew me into the world of patient advocacy. The process to become this voluntary PFAC member was lengthy and frustrating due to hospital protocol. This was a different type of volunteer position, one that didn't have direct patient interaction, one that didn't require being on a hospital floor. It was one that needed access to certain meeting rooms, needed tours of ERs and specialty clinics. But I went through it because honestly, I was fascinated by the whole idea that I was looked upon to give my opinions and perspectives. Some background why I'm even qualified to be a patient advocate. I have sickle cell anemia, a genetic blood disease that one is born with that causes abnormal red blood cells that are half moon shaped. This shape reduces the amount of oxygen traveling through the body, so organs do not get the necessary oxygen supply to function at a premium level. Also, the sickle cell shape does not flow properly through the veins, and when they get to the joints, the cells clump together, causing severe pain. Sickle cell manifests itself differently in each person. For me, it's a daily life of feeling sick, like I have the flu every day. Also, it means daily baseline pain level, plus severe pain crises that require ER visits and or hospitalizations. Decades of struggling in the healthcare system to receive proper care for me was exhausting in so many ways. Plus, I had to deal with the racial and drug-seeking stigmas that come along with living with sickle cell, making my experience as a patient frustrating at best. As I started coming into my own as an adult, I started to verbalize my needs, what was and wasn't working for me. I realized I had to create engagement within my own care, where collaboration with providers was key. Advocating for myself is something I had to learn because I realized two things. No one was actively engaging with me unless I initiated it. And two, self-advocation is required in order to get the personalized patient care that I needed. Once I understood and accepted those realities, my experiences with my providers changed. They became one of collaboration, of care that was consistent engagement. This self-advocating method became apparent to my hematologist. She was also heavily involved in research. So one day she asked, would I be interested in being a patient participant in a drug study she was involved with? This was my introduction into medical research. All of these experiences became the foundation that would prepare me for the work. My involvement with PFACs and medical research grew. My tenure as a PFAC member included being patient chair of emergency services and an oversight committee for the whole hospital. I collaborated with hospital staff, providers, other patients, and caregivers. We worked on new signage in the ER that was user-friendly for all patients, created a triage first process for the ER check-in, designed ER room layouts regarding comfortable chairs, soothing paint colors, etc. Created and updated information packets and brochures given to patients. Creating, implementing, and evaluating patient studies. I can say that the first time I went to the ER as a patient and experienced the changes that I had been a part of, I cried. I experienced the changes firsthand as a patient. Being at the table and letting my voice be heard inspired tangible change, not only for myself, but for many other patients. My research participation also increased. The ones that I participated with my hematologist seemed easy because all of my in-person requirements were incorporated into my regular scheduled medical appointments. My hematologist always gave me updates on the progress of the studies I was involved with. Information was being shared with me consistently. So this made me feel that I was a part of the process. I also began to participate in other studies where I didn't know the researcher, and the difference was startling. I only met with those researchers briefly. I dealt more with the research team members. My schedule wasn't a concern for in-person visits. Updates were few and far between, so I didn't have a positive experience in those studies, but I still participated. After several studies, I became very disenfranchised with the whole research experience. Plus, it was unfortunate that my hematologist moved to another state with her family, and so I lost that connection. So when done with the few studies, I didn't participate in medical research for many years. But in the meantime, I was still serving on numerous PFACs, and my story was being heard by hospital administrators, providers, and care professionals. This opened the door to statewide exposure to become a patient advocate speaker. Over the years, I have spoken at conferences, seminars, and meetings for numerous hospital systems and organizations. And the healthcare community started to reach out, letting me know that my patient story had made them think differently about patient partners. The snowball effect of personal recommendations, basically word of mouth from those looking to engage patients, led me to becoming a grant reviewer, a panel speaker, a patient co-PI, engagement training co-creator, advisory board chair, study design, and focus group facilitator. Willing to commit your time, ability to listen, problem solve, create community relationships, the capacity to learn new things was what was needed to have multiple roles in medical research. Along the way, I have met patient advocates who have been doing this work for years. So I created my mentor network of people who challenge, teach, but most of all, encourage me. They have been guiding me to seek out, be, and create resources in order to understand all aspects that come with participating in medical research at all levels. This training from seasoned advocates has been crucial for my many roles. This work is challenging, but we must realize we are participating in these roles in order to invoke change in research culture. Barriers exist that hinder patient engagement within research. It's not easy to be at the table with people who hold higher degrees, who lack an ease to have patient embedded in their studies from the very beginning, where there is low level of regard for the patient voice, lack of funding for patient engagement, underrepresentation of minorities in studies, etc. Plus, I personally have had experiences that were hurtful, dismissive, embarrassing, and degrading because I asked a question, voiced my opinion, or simply said, can we do something different? I have survived these moments by tapping into my mentor network of experienced patient advisors that I've created who have made it clear they're available to listen, teach, and support me. The greatest skills that I have had to lean on the most in these positions is patience, grace, and understanding that change in culture takes time. Patient engagement in the research world is a fairly new concept that now is deemed as important and required. So everyone is learning this new landscape. Having patients engage in studies help to facilitate collaboration within the process for researchers, lessening fear by offering information, transparency, understanding, and guidance so researchers are comfortable having patient input, not as an afterthought, but as a blueprint for success for research projects. These roles, These roles were the culmination of my lived experiences as a patient with a chronic illness. My involvement in research has been vast and it continues to grow because I learned to self-advocate for myself. And in turn, along the way, others helped me understand that my research roles were just by asking me, would you like to participate? Such a simple question, but being invited sharpens the skills of engagement, collaboration, and listening with the hope to improve each research study one at a time. These studies will make a difference for all patients and their families. So, but in my opinion, that's everyone. So I thank you for listening to my experience in the roles that I have played in patient advocacy. Thanks.
Thank you, Cheslie. And as I'm listening to you and I was listening to Joseph, I was thinking, I'm so glad I went first because you both are a really hard act to follow. Cheslie, I'll just quickly remind people, I see somebody has already dropped quite a challenging question into the Q&A, Paul, so we'll come to that question. But before we do, I'm just struck by a couple of things, Cheslie. There's actually a lot of things I was struck by, but one thing was, and I wrote it down here, you said this is exhausting. And I wonder, do you find that there's enough recognition given to the fact that when somebody is at the table, they're bringing their health condition with them. They've got a professional life, possibly. They've got family commitments, and they're not being paid in the same way as the other members are being paid around that table. And have you found, Chesley, that that has actually been a barrier for you in your participation? Or would you like more recognition of that? Or have you received recognition of that?
I have been fortunate where I started in a volunteer capacity, but throughout the work of doing that, you know, people were learning more about me and the kind of work that I was doing in the sense of being a volunteer. And from there, it just snowballed into people asking me to participate in this, to speak at that. And then that's where I began to be compensated. It started as a passion. It's a passion for me. This has changed my life. It's a second career for me. After giving birth to my daughter, I decided to be a stay-at-home mom, and that's how I got into volunteer because when she started preschool, I had extra time on my hands, and I was like, "What am I going to do with all my time?" And so I look at it as I've come to the table not only in a volunteer capacity, but also reminding everyone that when you are starting a research project, funding for engagement is highly important. It's highly important because we as patients, we come to the table not only with a medical condition that is typically very chronic and time consuming, medically, um, insurance draining, financially, physically, mentally. So it is an honor to be recognized and be paid for our time when sometimes we don't even feel good. So
Yeah.
I try to remind any board, any activity, any type of research, anything that I participate in, that compensation is highly, highly important in order to give value to what we do. And compensation doesn't always mean monetary. There are many things that can be that advocates are asked to do, such as complete a survey. And compensation can be a gift card or certificate to your local ice cream shop. It can be to anything, and it doesn't have to be expensive. It could be sometimes just acknowledging and sending a birthday card when that patient advocate's birthday comes up. It makes such a difference. It is very hard. It's very exhausting to share your story and be so open with strangers.
Mm,
But
mm,
in doing so, you change the landscape of how researchers can interact within what they want to do because they have a
mm,
face.
mm. I actually want to bring in a comment here from Isabel. I'm trying to multitask. I'm listening to you, but I'm also just keeping an eye on the chat. And Isabel has said, and I think this is a really important point, that while patient expertise different than but equal to that of other professionals in the team. What we bring is often based on trauma and difficult personal experiences. This is exhausting, but that can be mitigated by others on the team, recognizing and acting on our expertise without our needing to either convince them of our value or our right to be there. So I just thought that was a really important comment to bring in. There's lots of other comments there. So I encourage you to just keep an eye on them. I'd love to speak to them all, but I'm just not going to be able to. But I really think that's important to bring that piece around trauma into the conversation. So thank you. And the other piece that I just wanted to say to everybody, and Cheslie, just building on what you're saying, for those of us who are lucky enough to be in a position that we're actually able to perhaps do this work and it doesn't cost us maybe because we're financially lucky enough to be in that position. But if we only communicate, if we only have people in those roles that are able to do that because financially they're covered, then we're actually excluding people who should be at that table who cannot do it for financial reasons or just even physically getting to a place. They may not even just be able, they may not have transport. So it's just that recognition as well that sometimes paying is not just a nice to have, it's actually necessary to bring in some more voices.
Yes.
Okay, so I'm just going to quickly go and oh, we've got 3 Q&As. Let me see. Okay, so they're actually quite tricky questions. So I'm going to combine Paul's and John's. So Paul has said that the healthcare systems are different around the world, from being universal to being profit-based, as we know. And how does that change how patient advocacy groups are formed and how they are viewed? And then John's question, I think, really is a follow-on from that. Is there a model of global best practices for patient partners engagement and research? And he's given an example there as well. They're actually quite tricky questions to answer, and I don't really want to put the spotlight on you, Chesley. I can certainly say that in my own work, which is global, there's a huge difference. But even in countries and settings where it's advanced more, there's still a lot of challenges. I'm not sure if you'd like to also maybe speak to that question from John and Paul.
Yes, the challenges are overwhelming and the challenges are different in even in one country, but the challenges are different in the regions of the country. And what I've realized is that we serve as a blueprint for others to watch what we're doing and to incorporate into what they're doing. We may not always get it right the first time. We may not always understand the first time, but the point is that we continue to do the work and we continue to invite the community that we live in at that table. Because sometimes that community might be very different than your experience on the other side of town. So it's important for us to continue to understand and acknowledge those differences and challenges, because when we deny and we don't speak the truth, we're not transparent, we can't get anything done. And that's where I've always come upon when I do my work, is that I really, really do pay attention and listen and observe what is going on around me, because that really does help shape what I say, how I react, and what I get involved with.
Thank you. I want to take the pressure, the spotlight off you for a moment, Chesley. And I'm going to turn to one of the challenges is ensuring that, and you're going to hear this a lot, I am sure, over the next few days, but it's a real challenge. It's ensuring that patient roles aren't symbolic. And I believe that Josef has reflected on this, and we're going to hear his perspective now. Hopefully, all going well.
Thank you for that question. Tokenism happens when the patient voice is treated as an afterthought. Sustainability begins when our voice is built into the very architecture of this institution. From my journey, I see three essential pillars. First, we must move from voluntary participation to professional partnerships. On the IRB, I wasn't just a volunteer. I was a stakeholder with a unique expertise, my lived experience. Institutions must formally recognize and compensate this expertise, the same way they would any other specialist on a research team. This is not a favor. It's what makes the role sustainable and respected. When you pay someone, you send a clear message that their time and insight matter. Second, it's about investing in capacity building, not just consultation. This has been the heart of my work with FREB. We don't just bring patients to the table. We teach them about the table itself, how research ethics works, how to review protocol, how to be an effective board member. Institutions must provide this training. It empowers patient partners to contribute meaningfully, and it shifts the dynamic from being a token patient to being a knowledgeable colleague. Finally, and most importantly, it's about sharing power at the systemic level. Tokenism is when you have one patient on a team. Sustainability is when patients help design the team, set the agenda, and govern the process. My role on the FREB board isn't just to give an opinion. It's to help write the national guidelines that shape how all patients will be engaged in research. This is what genuine power sharing looks like. So in short, compensate our expertise.
Thank you, Joseph. I love how smoothly that happened. That was really, as I was listening to Joseph, I was also quickly looking at the chat, and I just wanted to acknowledge what John said. If the PPI group, and that's patient and public involvement in my world, I hope it means the same thing for everybody around the world. If the PPI group doesn't reflect both the varied ethnicities and economic realities of our population, it will also be difficult to ensure their inclusion in the research program strategy. I just think that's a really important point that John made. And then Mel made a point that finance can be a challenge and barrier to involvement for some people, and PRPs, not sure what PRPs are, patient, I'm not sure, can be hesitant to accept payment due to the risk. This is so important of losing income. So I think that's a really important point as well. So I agree, Mel agrees, oh, the chat is flying now, agrees that the reciprocal value, as Cheslie said, can also go beyond money. And Mel wrote a blog piece about that. And somebody else pointed, Grace Cordova, I think, she has a piece on it. So again, really encourage you to have a look at that chat. You're going to learn as much from the chat as you are from the conversation here. One of the things I just wanted to acknowledge in the Q&A as well, because I hate to see Q&A and not acknowledge the question. So it was actually a question from Paul about social media groups. And Paul, I just wanted to say that just for this session, we're just going to focus on roles. So it's a good question, but I'm not sure that we're actually just going to be able to address it now. But hopefully you will get that question addressed as we go along the next few days. Lynn, how do we implement First Nations data and information will be collected, protected, used, or shared? So Lynn, I am not the person to answer that. I'm not sure if Cheslie is, and maybe there needs to be a system. We can certainly talk to Dawn about this and to the organisers if there's a way to perhaps get these questions answered at different points during the next few days, because I hate for people to ask questions and we don't get to answer them. So I hope that's okay. And the minute I have said that, all the questions close down. Cheslie, I am going to ask you actually just a slightly different question. So we've described myself and yourself and Joseph, some of the roles, and they've been quite varied, that we've held as patient partners. Now, if we think of those roles, not just as titles, and I know, Cheslie, you mentioned some of your titles, but as a set of skills. What skills do you find that your roles have drawn on most heavily? And the second part of this question is, were there any skills that you found you developed along the way that actually surprised you and you went, oh, I didn't know I could do that, but look what I have done. So could we talk a little bit about skills and what skills we draw on as patient partners?
And for me, the skills have been of being a kind human. Those are the skills that I've really had to work on the most because sometimes in meetings, um, I've had to be very respectful and above board because I wanted to make sure the work is done instead of it becoming something else.
Mhm.
Other skills that I've used is organization, time management,
Mhm.
um, being able to listen. I've become a better listener. Um, I understand better now the other side of the coin. You know, I've always seen it from my perspective, the patient perspective,
Mhm.
but I have learned so much about the research perspective. The
Mhm.
researchers go through a lot. It's a lot. It's a lot of time, a lot of disappointment. It's a lot of chasing to see where they can find funding. And it's a lot of trying to understand, am I doing right by the engagement piece of my project? And some of them don't know what true engagement is. So it is a learning process. You know, it's good that the attitudes have changed, that engagement is necessary to have a good research study out there. Um, so that is a good thing, but we have to understand that we all have to be patient, we all have to listen, we all have to compromise, and we all have to problem solve in order for things to move forward. And those are the skills that have really popped up the most for me.
Mhm.
And I had them, you know, generally speaking, but I think I've, you know, sharpened them, so to speak.
I love that. I love that, Cheslie, because I think as patients, when we come as patients, we do talk more than we listen because we have so much to say and we haven't been heard before. And that's natural. That is natural. So I love what you say about I actually, have to learn as well to sit back and to listen. And there's a humbleness in that, not in a I don't deserve to be here, but there's something really beautiful about that if you bring that humbleness to it, and that works on both sides. And that's really where the partnership is that we actually both have to hear from each other. I think that's really lovely what you said. It's interesting, Chesley, because you say you learned to listen. I actually learned to talk. I was very shy and I had to go out of my comfort zone. People don't believe that I was shy, but I really was. And I was afraid to speak up and I was really self-conscious, but I had to learn to do it. I had to learn to speak and to speak my truth. That's one of the things you talked about as well, Chesley. And I just had to get out of my own way and say, I'm not doing this for me. I'm
Mhm.
doing this for my community as well. And so that was the skill that I learned. And now I teach that skill. So somebody asked in the Q&A, what is, and I'm going to ask you this question as well, Chesley, what is the favorite role you've had as patient partner and why? And my favorite role is actually now working with patient partners to say, you belong at the table and here's how your voice can be heard. And I feel now, Chesley, I need to learn from you that I also need to say, this is how you listen as well. So I've learned from you today, Chesley. And I think that's one of the things about our role. We never stop learning. And if we're humble enough, we should never stop learning. And it is that learning journey and it will go on and on. Another question. When is it appropriate to ask about compensation? Should the time for initial onboarding interviews be compensated? I always feel awkward asking about this. I'm actually going to answer this if you don't mind, Chesley. I don't think it's our role to ask for compensation. I don't think we should ever be in that position that we feel we have to. And I think when researchers work as a team, all of this should be in place beforehand. Before you ever approach a patient partner, you should be very clear on hope that as a team you will work together and what you will achieve, not just there, to go back to Joseph's point about tokenism. So be very clear. And if you feel that a patient partner will not bring something substantive to the table, then don't ask them. And if you're not prepared to have that awkward conversation among that team about paying them, then you need to really consider. You need to consider how you can actually work that into your research proposal from the very beginning. So, Aaron, to answer your question, I really don't think that it's our role to ask those questions. I think it should be something that's already been worked out by the researchers and research team. Cheslie, what do you think about this?
I totally agree with you because, but the funding sometimes isn't there. But what
Mhm.
I have done for my own personal sanity is when anyone approaches me and says, we would like your input, your opinion, your this, your that, I say, oh my goodness, thank you. You feel that I'm bringing value to the table. And they typically answer yes. And then I say, so what value are you bringing to my table? And
Oh,
that
Cheslie, I love
opens
that.
a conversation of, it's not anything, it doesn't become as uncomfortable, I find, because you have acknowledged already that I'm bringing value to your table. So what value are you bringing to my table? And people
I love
answer
that.
it honestly and civilly because it was approach that way.
I love that. And Chesty, it's brought something else up for me. You and I we've been doing it for a long time. As I said, we don't look like we have. We must have started very young, but we've been doing it for a long time. And we are able to speak up for ourselves. And for those who are perhaps listening in and feeling that those conversations are awkward, and Chesley, you spoke about mentorship, about, having, it's so, so important that we can mentor each other. And I would just like to say that I'm open for anybody who wants mentorship as well and to have those awkward conversations. And I love that Chesley said, it's very simple. This is what you say. And even if we had those scripts that we can share with each other and say, this is how we have those awkward conversations. So learn from Joseph, learn from Chesley, learn from me, learn from those of us who have been in this space and who have really fought to have our place at the table. And really, we need to keep moving forward. As Chesley, I think you said that as well. We need to keep moving forward. And we need to bring the next generation of patient partners. We need to raise up. So, what do they say? A rising tide carries all boats. So, we need to do that as well. I'm just conscious that that feels like a nice way to wrap things up. Really quickly, I'm going to look in the Q&A. So Paul has lots of questions. He's asking if there are no patient advocacy groups, how do you start one? I think Joseph would have been very good to answer that question. Again, maybe we could talk just offline about how we get those questions answered that Chesley and I have not been in a position to answer. I don't know, Job, if I'm putting the spotlight on you, but just before I hand over to Job, I just want to say thank you so much to everybody. Thank you, Chesley. Thank you also to Joseph for contributing your perspective with us today. I guess what stood out for me so much in that conversation was how we all started with a supposedly simple. Chesley, you said it was a conversation, it was a question, something simple, and look where that brought you. And Joseph and I both talked about story. So those simple moments are not simple, and it's where they lead. So I want to thank everybody. I know Job is going to give his thanks as well, but I just really want to thank you for your engagement in the conversation, in the chat as well, and for your thoughtful questions. It's been such a pleasure to share this session with you. So I'm now going to hand back over to Joe, who will wrap this session up.
Thank you. Thank you so much, Marie. It's been such a wonderful session, and maybe I can quickly just give some things I took away from you and from Chesley as
Please.
well. Thank you so
Yeah.
much, and Joseph. So from you, Marie, I took away we're story shapers. I've never had the term, that's new to me, and kind of tell a story that research needs us to tell. I've always seen it's my story, so kind of shaping my story in a way that is useful in research was very profound to me. And then from Joseph, of course, being loud, clear, and informed patient voices is a theme of being informed beyond our stories, beyond our lived experience, being informed that's relevant to research is super important. From Chesley, so much, but I would say learn the researcher's perspective. I've never thought about it that way. I always bring our perspective, but then also seeing where they're coming from, really profound, looking for common ground as a team, because at the end of the day, we're really pushing to become partners. And to do that, we need to be able to see each other's perspectives and make this table better, build this table. So those are the things I've taken away. But I'd just like to thank you, Marie, thank you, Chesley, and to thank Joseph as well, who was able to record a video. It was such an insightful conversation. We're going to take you up on following you as our mentors. I really like that. As someone who's newer in the space and others who are new in the space, please look for Marie, look for Chesley, look for Joseph. If they're willing to take us as mentors, we should take them up on that. So we will look for you.
Thank you, do
Yeah,
please. Thank you.
we
Thanks,
will.
Joe. Thanks, Chesley. Thank you, everybody. Bye. Enjoy the rest of the day. Bye bye.
Bye. So we're going to take a 15-minute break and come back for our third session, which is Journeys of Impact, the Pathways of Patient Partners. So enjoy your break and see you in a bit. Thank you so much.